Hello everyone. So I am going to share the link here. You can see palatine tonsil and soft palate. The SLOs for these topics are morphology, relation, blood supply and applied anatomy of the palatine tonsil, and what is the composition of the palate. Okay. Here specifically we will see the soft palate. What is the anatomical basis of tonsillitis, tonsillectomy and peritonsillar abscess, and component and function of Waldeur's ring. Now, first tonsil, as you already know, the tonsil is nothing but aggregates of lymphoid nodules in nasopharynx and oropharynx. There is something you can see here, palatine tonsil, there will be pharyngeal tonsil and the tonsil present in the tongue, those are lingual tonsil. And already I have told you, this is the Waldeur's ring, you can see the pharyngeal tonsil, tubal tonsil, palatine tonsil and lingual tonsil. Now, palatine tonsil is aggregates of lymphoid nodules at the entrance of oropharynx. Okay, it's not oral pharynx, it is oropharynx. Okay, so I have shown you in the dissection hall also. You can see here is the tonsillar fossa where the tonsil is located. So there are two palatine tonsil. Each tonsil is, whenever if nothing is specified, then if they are asking the tonsil, then it is palatine tonsil only. Each tonsil is almond shaped mass of lymphoid tissue situated in triangular fossa, that is tonsillar fossa of lateral wall of oropharynx, between the anterior and posterior pillar of fossus. Anterior pillar you can see here, that is the palatoglossal arch, and posterior pillar, that is formed by palatopharyngeal arch. Okay. So what are the boundary of the tonsillar sinus or tonsillar fossa? Tonsillar fossa is the space where the palatine tonsil is lodged. So anteriorly palatoglossal arch, in which the palatoglossal muscle is there. Posteriorly palatopharyngeal arch, where the palatopharyngeal muscle is there. Apex is the, here is the apex where the both arches meeting, that is at the soft palate, and base is the dorsal surface of the posterior 1/3 of the tongue. And lateral wall, or which is not visible here, that is the tonsillar bed, which is mainly formed by the superior constrictor muscle. Now you can see here, this is the tonsil here. So behind that, whatever structures are there, they are forming the tonsillar bed. So from within outward, you start from here. So there will be pharyngobasilar fascia, superior constrictor muscle and buccopharyngeal fascia. Remember, these three were there as the coat of the pharynx. Now palatine tonsil, if you see the external feature, so this is the medial surface which is free and bulging into the oropharynx, and it is lined by the same epithelium which is lining the oral cavity. As I have already told you, non-keratinized stratified squamous epithelium. And here you can see the crypt. These are tonsillar crypt. These are nothing but dipping of epithelium into substance of tonsil. There are 12 to 15 in number, and among them, one of them is very much large and deep. It is known as crypta magna or intratonsillar cleft. It represents the second remnant of the second pharyngeal pouch. I have told you in embryology how the development of tonsil is there. Okay. Now the lateral surface, what you are seeing here, this is the medial surface. What is seen here, that is the lateral surface, which is towards the tonsillar bed. So it is covered by hemicapsule. Why I am saying hemicapsule? Because capsule here is not completely covering the tonsil. So there is something known as peritonsillar space. It is present between the capsule and the tonsillar bed. Okay, and it is site of collection of pus in the peritonsillar abscess. Okay, you got it? This is the medial surface, this is the lateral surface. Lateral surface only is covered by the capsule, and the space between the capsule and the tonsillar bed here, that is known as peritonsillar space. If there is abscess in that, that is known as peritonsillar abscess. Now you can see here superior surface. So superior surface is here separating the lateral surface from the facial artery and two of its branch. Here two of its branch which are given in the neck, the ascending palatine and tonsillar branch Also, what other structure are separated by the superior constrictor from the tonsil is, one is styloglossus muscle, the coming from stylohyoid to the tongue, and then there is glossopharyngeal nerve. You can see here a nerve is there, a muscle is there, and branches from the facial artery. Styloid process, if it is elongated, that also will be separated from the here tonsil by this superior constrictor, and there may be this submandibular salivary gland. So all these structure are separated from the lateral surface of the tonsil by this superior constrictor. Now if you see here the anterior border, so anterior border is here, this one is passing underneath the palatoglossal arch. Posterior border, I am talking about the tonsil, so posterior border is passing underneath the palatopharyngeal arch. Here is the upper pole, here is the lower pole. Upper pole is extending into the soft palate, and the medial surface is covered by semilunar fold extending between the anterior and posterior pillar, and it is enclosing a potential space that is known as supratonsillar fossa. So here will be supratonsillar fossa. Then there is a lower pole, it is attached to the tongue here by a band of fibrous tissue that is known as suspensory ligament of the tonsil. So you can see the tonsil here, what is visible here, upper pole, then here is lower pole, here is anterior border, here is posterior border, here is lateral surface, here is medial surface, here is lateral surface. What are the arteries supplying the tonsil? So as you know already, ascending pharyngeal, the only medial branch from the carotid artery. Then there is facial artery, which is giving these two branches in the neck, tonsillar branch and ascending palatine branch. Then there is lingual artery, which is giving dorsal lingual branch, which will supply the tonsil also. And from maxillary artery, remember the third part of the maxillary artery, so in that greater palatine artery, which will give one branch that is known as descending palatine, that also will supply the tonsil. So you can see all the branches. This is the tonsil. You can see here the ascending pharyngeal, which is giving here the palatine branch. Then here is the facial artery, which is giving ascending palatine and tonsillar branch. Then here is the lingual artery, which is giving the dorsal lingual branch, and here from maxillary artery, third part of the maxillary artery, that is giving the greater palatine, from which one tonsillar branch or descending palatine branch will come. Okay, venous drainage of the tonsil, it is into the paratonsillar vein, which is draining into the pharyngeal venous plexus. Okay, then lymphatic drainage, it can be into upper deep cervical. Remember, upper deep cervical, jugulo-digastric nodes. Okay, and nerve supply, it is supplied, tonsil is supplied by glossopharyngeal nerve and the lesser palatine branch of sphenopalatine ganglion. Okay, sphenopalatine ganglion is nothing but the pterygopalatine ganglion. Okay, now applied anatomy, tonsillitis, and specifically we will say acute tonsillitis because it is most common in school going children and it is involving viral infection. Okay, so here you can see the what can be the reason to have tonsillectomy, why you need tonsillectomy. Okay, if there is tonsillitis, if there is sleep apnea related to the enlarged tonsil, or there is recurrent strep throat, there is frequent chronic infections, there can be anesthetic complication, or there can be these are the risks which are related with the tonsillectomy. There might be infection, there may be bleeding, there may be anesthetic complication, and these are the reason why tonsillectomy should be done. Okay, then apart from acute tonsillitis, there can be acute follicular tonsillitis. Here the infection is spread into the crypts and it is become filled with the purulent material presenting at the opening of the crypt. It is seen as yellowish spot, and bleeding from the tonsillar fossa after tonsillectomy can be due to damage to the paratonsillar vein. Okay, remember, bleeding is not because of the artery, but bleeding is because of bleeding from the paratonsillar vein. Okay, What is peritonsillar abscess? So peritonsillar abscess, because of this infection of the tonsil, it can reach either to the retropharyngeal space or peritonsillar space, so that will be leading to the retropharyngeal abscess, okay, or there can be peritonsillar abscess, okay. So that is about the tonsil. Now come to the palate, okay. Here you see this is the sagittal view of the palate. You can see this is the bony part and this is the soft part. So palate consists of two parts. You can see here inferiorly, you are seeing from below and you are seeing the sagittal view. So palate consists of hard palate, which is anterior 4/5, and soft palate is only the posterior 1/5. Okay. Now the hard palate, you can see here there is maroon color and green color. So these are two bones which are contributing for the bony part of the palate. So hard palate is forming partition between nasal and oral cavities. This is the nasal cavity here, here is the oral cavity. So hard palate, I already told you, I am repeating, the palate consists of hard palate and soft palate. In hard palate, this is contributing for anterior 4/5 of the total palate, and soft palate is forming the posterior 1/5 of the total palate. Okay, now we are focusing on only hard palate. So in the hard palate, anterior 2/3, what you are seeing, this maroon color or brown color, that is by the palatine process of the maxilla. Okay, you can see here maxilla. If you see, read individual maxilla bone, there will be alveolar process where the tooth socket will be there. There will be the palatine process which is contributing to the hard palate. Okay, so anterior 2/3 of the hard palate is contributed by the palatine process of maxilla, and here this green color, that is the contributing to the posterior 1/3 of the hard palate, and it is formed by the horizontal plate of palatine bone. Okay, now if you see the hard palate, so now if I am showing you here from the below, okay, so this is the hard palate. So the superior surface of the hard palate forms the floor of the nasal cavity, and inferior surface of the hard palate forms the roof of the oral cavity. Anterolaterally, it is continuous with the alveolar arches and gums. I have already shown you, here are the alveolar arches where the sockets, tooth sockets will be there, and posterior margin of the hard palate is free here, and it is giving attachment to the soft palate. You can see the inferior view, or you can see here the lateral view, sagittal view. So the posterior margin of the hard palate is giving attachment to the soft palate. Now here if you see the inferior surface of the hard palate, there will be three features. One will be incisive fossa, and within that there will be incisive foramina and incisive canal. So here the vessels and nerves from the oral cavity, they will be going or coming from the nasal cavity. Then there will be here the big foramina, that is known as greater palatine foramina, and you can see small foramina, that is lesser palatine foramina. Okay, obviously greater palatine foramina will give way for the greater palatine vessels, the branch from the third part of the maxillary artery. Okay, now you see here the soft palate. As I mentioned earlier, soft palate constitute of the, here the posterior part of the total of the palate. Okay, it is mobile muscular flap hanging from posterior border of hard palate here, and it is separating the nasopharynx from the oropharynx. So here is the nasopharynx, here is the oropharynx. Now external feature of the soft palate. So if you see here, this is the soft palate. We can call this anterior or the oral surface, which is concave and marked by a median raphe. Okay, and this is the posterior surface, which is actually nothing but continuous with the floor of the nasal cavity. And also during nasopharynx class we have seen, this is here forming the floor of the nasopharynx also. So that is the surfaces of the soft palate. Now superior border, okay, superior border is here, superior border is here, okay. So this is attached to the posterior border of the bony hard palate, and inferior border is here. This is free and it is forming the anterior boundary of the pharyngeal isthmus. Okay, remember this is the pharyngeal isthmus here, the communication between the nasopharynx and the oropharynx. Now here you can see one small conical small tongue-like projection that is hanging down from middle of the soft palate. It is known as uvula. What is the arterial and nerve supply? So there is nasopalatine nerve, there is greater palatine artery and nerve, there is lesser palatine nerve and artery. So as you already know, greater palatine artery is branched from the third part of the maxillary artery. All these nerves what you are seeing, they are coming from the pterygopalatine ganglion, and actually they are branches from the maxillary nerve. Now this is histology feature. I am not going in detail because that is not needed for you, okay. But you can see here, if you see here the posterior surface which is continuous with the nasal cavity, so obviously that will have the epithelium which is covering the nasal cavity, that is nothing but pseudostratified ciliated columnar epithelium. And because the anterior surface is continuous here with the oral cavity, so it will be having the same epithelium as what is present in the oral cavity, that is non-keratinized stratified squamous epithelium. Now when you see the soft palate, it consists of all these muscle. There is tensor veli palatini, there is levator veli palatini, there is palatoglossus muscle, palatopharyngeus and musculus uvuli. Okay, you know about these two muscles already. We have seen these are passing through the gap between the base of the skull and superior constrictor. Palatoglossus, you have seen, it is present within the palatoglossal fold. This is present within the palatopharyngeal fold, and this is present within the uvula, that is musculus uvula. Okay, now see here, there is tensor veli palatini. You already know tensor veli palatini. It is coming from the which arch? It is coming from the first arch, and we know nerve supply of the first arch is mandibular nerve. So what is the origin? You just remember, it is originating from auditory tube and also greater wing of sphenoid. Okay, just remember this auditory tube, where it is inserting. It is inserting into the posterior border of the hard palate and inferior surface of the hard palate. This is the direction of the fiber. So that is why it is tensor veli palatini. What is the nerve supply? I have told you already. It is supplied by the nerve to medial pterygoid. So if you see, the nerve to medial pterygoid comes from the trunk of the mandibular nerve. It supply first medial pterygoid, then it supply the tensor veli palatini, and ultimately in the last it supply the, you can see here, the tensor tympani muscle. What it do? It tightens the soft palate and it help in the opening the auditory tube. So that is tensor veli palatini. Second one is levator veli palatini. You can see the direction of fiber. It is also coming from the auditory tube, plus it is coming from the petrous part of the temporal bone, and it is inserting into the upper surface of the palatine aponeurosis. Okay, here, and levator veli palatini is supplied by the cranial root of accessory nerve. Remember, accessory nerve is 11th cranial nerve. What it do? It elevate the soft palate, and this also help in opening of the auditory tube. Then there is musculus uvuli. It is attached to the posterior nasal spine and palatine aponeurosis. Can you see here? This is the palatine aponeurosis. Okay, and it is inserted into the mucous membrane of uvula. It is also supplied by the cranial part of the accessory nerve, and it pulls the uvula forward to its own side. Then there is palatoglossus. It is supplied by the oral surface. It is originating from the oral surface of the palatine aponeurosis. Okay, and I told you already, it is present within the palatoglossal fold. It is inserting into the side of the tongue at the junction of its oral and pharyngeal part. So if you are seeing, here is the tongue, okay, or here is the tongue, okay. So it is inserting into the junction of the tongue between its oral and pharyngeal part. It is also supplied by the cranial part of accessory nerve, okay. It pulls up root of the tongue. It approximates palatoglossal arch to close the oropharyngeal isthmus. So now you see here is palatoglossal fold, here is palatoglossal fold, within which the same muscle will be there. So they will be approximated with each other. So this oropharyngeal isthmus will be closed. Food will not be returning back into the oral cavity during deglutition. Okay, then there is palatopharyngeus. So it has two fasciculus, anterior fasciculus and posterior fasciculus. Anterior fasciculus comes from the posterior border of hard palate, and posterior fasciculus comes from the palatine aponeurosis. They will be inserted into the median fibrous raphe. Remember median fibrous raphe, where all the constrictor of the pharynx will be inserting, okay. So it is also supplied by the cranial root of accessory nerve, and it raises the wall of pharynx and larynx during swallowing, okay. So these are the muscles of the palatopharyngeus. Now, as I mentioned you, there are four structures for which we will use the sentence all the muscles of the dash supplied by dash except dash which is supplied by dash. Now we have already done for tongue, we have already done for pharynx. Now it is time for palate. So in case of palate, you can see here all the muscles of palate are supplied by, you can see here, cranial root of accessory nerve except tensor veli palatini, which is supplied by nerve to medial pterygoid, okay. Then what is passavant's ridge? So it is here, the passavant's ridge is nothing but it is a mucosal fold which is raised by the fibers of two muscles, palatopharyngeus and superior constrictor. So you can see the superior constrictor here, you can see the palatopharyngeus here. So here one mucosal fold will be, okay, or you can see here there will be one mucosal fold. So when these two muscles are contracting together, so this mucosal fold will be raised, and this passavant ridge will encircle the lateral and the posterior wall of nasopharyngeal isthmus. Here is the, remember, nasopharyngeal isthmus, communication between the nasopharynx and oropharynx. So this ridge will actually raised and it will be encircling the lateral wall and the posterior wall. So during deglutition or speech, this soft palate will come in contact with this ridge to cut off the nasopharynx from the oropharynx. So this is the palate here, here will be the passavant's ridge. When these are coming in contact, so here whatever food is there in the oropharynx, it will not going back to the nasopharynx. And sometime before we saw these palatoglossal fold also approximating, so food will not come back to the oral cavity also, so it has to go down, okay. What are the functions of palate? It separates the oropharynx from the nasopharynx during deglutition or swallowing. It isolates oral cavity from oropharynx during chewing so that breathing is not affected. It modifies quality of voice. It protects the damage of nasal mucosa during sneezing, okay. That is why whenever there is extreme pressure created during sneezing, so that soft palate will be closing and it will be protecting the nasal mucosa. It prevents entry of sputum into the nose during coughing, okay. What is the applied anatomy? So paralysis of soft palate or palatal paralysis. So here muscles of the palate become softened, weakened or paralyzed. Cause can be idiopathic, it can be neurological because of damage to the vagus nerve, cerebrovascular disorder, metabolic disorder, viral infection, tumor, trauma or surgery, and other causes can be inflammatory or autoimmune disease, botulism, Lyme disease or meningitis. What can be the symptom? It can be rhinolalia, where the nasal voice or speech will be there will be nasal regurgitation, swallowing difficulties will be there, dysphagia will be there, hoarseness will be there, and bilateral fixation of vocal cord will be there. Okay, so I have already told you about the soft palate. Now here you see what is the gag reflex. So this gag reflex, you can see here how the gagging is done. So this is the pathway being shown. I hope you will be reading this in physiology. Okay, so that is today's topic. Thank you.